Olá, é um prazer estar aqui com a doutora Tari King, que é chefe do programa de câncer do Dana-Farber Cancer Institute para mulheres, Dr. Guilherme Novita, que é mastologista, titular da Sociedade Brasileira de Mastologia, e a gente vai discutir alguns tópicos de cirurgia de mama, bem formais, basicamente as próximas tendências que a gente acredita que virão com os novos estudos. Tari, it's a pleasure to have you again in Brazil. We are trying to discuss some aspects of breast cancer surgery that will change our practice in the next years. What do you think about this?
Well, first of all, thank you. It's a pleasure to be back in Brazil. It's a wonderful meeting. I think that the most common theme that we've seen in breast cancer surgery over the last several years, and which will undoubtedly continue, is the trend towards a less is more approach. We know that we can safely do breast conservation therapy, even in high-risk tumors, even in young women. There's no survival advantage to doing mastectomies or even bilateral mastectomies. We've seen trends towards doing less axillary lymph node surgery. In women with positive nodes, we're no longer recommending complete axillary dissection in the setting of breast conservation. And in the setting of mastectomy, we're really trying to work together with our multidisciplinary team to determine when PMRT plus axillary RT can be substituted for axillary node dissection. So really trying to minimize the extent and the morbidity of local therapy for our patients.
Okay. Well, I have a microphone here. Thank you. Tari, as we are here talking to breast surgeons in Brazil, we have some topics that the people are always asking about. For example, can we extrapolate the data of the Z11 for patients without Z11 criteria? Because, in fact, all positive axilla patients, even treated with mastectomy, are going to receive radiotherapy in most of centers. Can we avoid axillary dissection for these patients also with mastectomy nowadays, or do we have to wait a new research or new data in some years? What do you think about it?
Well, I think when we consider mastectomy patients, we can look at data from both AMAROS as well as the International Breast Cancer Study Group trial. Both of those trials included patients treated with breast conservation and mastectomy, although the majority were breast conservation. But in both settings, for the International Breast Cancer Study Group trial, it was a micrometastatic population, and axillary lymph node dissection was avoided, and there were no increased rates of regional recurrence in women undergoing mastectomy without axillary node dissection. In AMAROS, it was largely the same population as the Z11 trial, and when you look at the mastectomy patients, they had equally good local regional recurrence with axillary radiation instead of axillary node dissection. So in our practice, what we are trying to do is to work with our radiation oncology colleagues to determine which mastectomy patients do they think they're going to recommend post-mastectomy radiotherapy. And in those patients, we actually have now omitted frozen section in the operating room for the sentinel node, because we know that if they do come back with positive nodes, they're likely to receive PMRT, and then axillary radiotherapy can be substituted for axillary node dissection.
What are your opinion about gross extracapsular invasion of the lymph nodes? Sometimes we find we don't do frozen section in sentinel nodes, but sometimes we find in the definitive exam gross invasion of the extracapsular lymph node. So maybe.
Yeah, so that's a challenging, clinical situation, because there's some confusion as to whether extracapsular or extranodal extension was a factor in Z11 or AMAROS or not. In Z11, it was clearly stated that patients with gross extranodal extension, so disease that we could see in the operating room, those patients were excluded. But there was absolutely no information collected about microscopic ECE in Z11 or AMAROS.
What do you do? Do you go back to the surgery?
So if we look back in retrospective data where, without the question of sentinel node and dissection, but just looking at what is the significance of extracapsular extension, microscopic extracapsular extension. And in the setting of, again, prior to the sentinel node era, when you look at those studies, extracapsular extension was associated with higher disease burden in the axilla, right? But there's no data that says that it's associated with higher failure rates in the axilla, just higher disease burden in the axilla. So when we have extracapsular extension in a sentinel node, in whatever the treatment setting it is, I think that information, you just have to consider that information when you're saying, what do I think this patient's disease burden is? Because all of these studies and all of this effort that we're doing is really to identify women that we think have a low enough disease burden that we can safely omit treatment. In Z11 and Amros, we know that disease burden was about 30% of women had additional positive nodes. We know that a very small percent, less than 5% in both of those studies, did they have 4 or more positive nodes. And so we're really just trying to identify that group where we feel confident that the disease burden is small enough or manageable with our adjuvant therapies. And so if you have a situation where you have, multiple positive sentinel nodes with extracapsular extension, that's probably someone who just has a higher likelihood of having a higher disease burden, right? And we showed that retrospectively in some data from Memorial when I was there as well. And so it just becomes a matter of judgment. I don't think there should be a blanket approach. Okay. ECE should be handled individually based on the other disease factors.
Tari, changing the practice, you have some papers published about bilateral mastectomy. Yeah. We have in Brazil a real problem with bilateral mastectomy.
Contralateral prophylactic
mastectomy and nipple-sparing mastectomy. Mm-hmm. We are seeing that surgery is less is more. Mm-hmm. For systemic treatment, less is more. And now we are using more molecular profiles. But I see that radiotherapy is always more and more. More nodes, radiations, and more indications. Is, I think, that's a real problem. I would like that you comment 2 things about radiotherapy after nipple-sparing mastectomy, mm-hmm. and about contralateral prophylactic mastectomy in patients that we can do.
Do you do
only
prophylactic
mastectomy without contralateral mastectomy?
Yeah. So I agree, the rate of contralateral prophylactic mastectomy has been demonstrated to be quite high across the United States. In other countries, we see that rate increasing as well. We see it very commonly in our young women, where up to 50% now of women under the age of 40 who are having treatment for unilateral breast cancer will have contralateral prophylactic mastectomy. In the absence of any survival benefit, right? Very large studies nicely done now trying to demonstrate whether there could possibly be any benefit for these women, and in terms of survival, no. We know when we ask women why they do it or why they choose it, they report, peace of mind, and they have a lot of fear and anxiety about recurrence. But yet they also say that they understand that they won't live longer. And so there's a disconnect really in this decision. What about
the symmetry between the breasts? Do you think that it should be considered or not?
I think that it is considered by many women. For some women, I think it is a bigger factor than for others. But I think when we're counseling these women about the risks and benefits or the advantages and disadvantages of these approaches, we have to remember that, yes, although symmetry may be better with the bilateral procedure, when you look at long-term satisfaction with these procedures, that there still is...
The problem is after 2-3 years, we don't have the same symmetry without equal surgery between the 2 breasts.
Right, but it's not only about, in the long term, it's not only about symmetry. The long term is still about satisfaction overall with the choice. And we know when you ask women several years after their decision about bilateral prophylactic mastectomy, there's a significant minority, 25 to 30% of the women, that say, well, I chose this because I thought that I would worry less about breast cancer, but I worried just as much as I ever did. Yeah. I chose this because I thought it would make me feel better about myself, but actually my self-esteem is lower. My sexuality is lower. I don't feel as confident. It required many more operations than I thought it was going to require. And so although initially, when women are facing the diagnosis and they're fearful and they're trying to justify their choices and thinking what they want to do, although up front it seems like this might be the right answer, once they've gone through the treatment and some of that fear is gone...
Let me ask you an easier question.
Mm-hmm.
A woman is going to look for you at Dana-Farber, and she's going to ask you, you're going to perform an episphere mastectomy because of multicentricity anyway. When are you going to do a bilateral mastectomy? Do you never do? Sometimes or always? What's your, where are you?
Never, sometimes, always. Those are not good. When a young woman or a woman of any age comes to talk to us about her surgical treatment options, I start the conversation with everybody as to whether or not they're a candidate for keeping the breast or removing the breast. That's the starting point, because you want to try to get the information into their minds that it's okay to keep the breast, even if they've walked in thinking that they know what they want, right? So I always start with keeping the breast is equal to removing the breast in terms of survival. Keeping the breast is equal to removing the breast in terms of this breast cancer coming back. Yeah. And then when they say, well, what about my other breast? I say, well, let's talk about your risk of getting a breast cancer in your other breast, because right now you don't have one. And so what is the chance of that happening in the next 5 years or 10 years? And then I try to line that all up for them with respect to the risks from the cancer they already have and the risks from the cancer that they think they're going to prevent by removing the breast, right? Now, do we do it? Of course we end up doing it, because for many women, that is there, even though we lay it all out and they say they understand, they still prefer bilateral mastectomy. There are some women, though, that once you lay it all out for them, they say, oh, I didn't realize that. Maybe I don't need to, remove both breasts. The biggest benefit, though, is that when we get women to realize that they don't need to remove either breast if they can keep the breast, and of course that has implications for radiation and everything. So, but yes, we do it, but we do spend a lot of time trying to educate women, again, about the trade-offs. What are you gaining? What are you losing?
Do you guide yourself by a genetic test or something, or?
So certainly in our patients that have indications for genetic testing or come with genetic testing results, we certainly incorporate those into the decision-making process. And because really, for the contralateral prophylactic mastectomy, all you're gaining is reduced risk of contralateral breast cancer. Yeah. And so if somebody has a high risk of contralateral breast cancer, then that operation may make more sense, opposed to the average woman whose genetics are negative, where her risk of contralateral breast cancer in the next 10 years, maybe 3 to 5%. And so I tell women, I say, your risk of getting a cancer in that healthy breast in the next 10 years is 3 to 5%. If I remove that healthy breast, it's going to go down to 1 to 2%. It's never going to be 0. And so I really ask them to really think about, is, a 2 or 3% difference, is that worth it to lose a normal healthy breast that has sensation, feels, they can, when someone touches them, they feel it, when they touch themselves, they feel it, etc. I say, what is the trade-off? And then you, of course, have to factor in the increased risk of surgical complications, which we know are double, and really ask them what that long-term gain is for them. So they're not easy conversations. They take a long time, but they're important, I think, to go through no matter what no matter what the woman's final decision is. I think it's important to encourage her to think about all of this in the decision-making process.
And finally, in Brazil, our radiologists are crazy for ultrasound evaluation for axilla.
After breast surgery?
No, not after breast surgery, before breast surgery. And the patients are coming to us with cytology with positive node in a patient that we are thinking to spare the axilla.
Yeah.
In the Annals of Surgery this week, it's published a paper by Morrow about 800 patients that they have positive cytology, and they applied the Acozogi in this patient. Half of them, there are less than 2 nodes positive. In Dana-Farber, are you using this practice for positive node in cytology?
So again, very, very challenging scenario. So if somebody comes in with a positive sentinel node in cytology, we have to make a judgment call. If that patient's going to have breast conservation, we have to make a judgment call that in our hands, if she would have come to us before having that cytology, would we have considered her eligible for Z11? And sometimes we will, ignore the cytology. If it's somebody that we said, this patient would have been eligible, we never would have got the ultrasound, we never would have got the lymph node, right? But those are tough conversations, and they're, you have to make those individually. So we prefer not to have the ultrasound. If someone is clinically node negative with early stage breast cancer in our hands, we don't do ultrasound routinely, so we don't go looking for that one abnormal node. If somebody has multiple abnormal nodes on that ultrasound with the positive cytology, so if it looked like there were 2 or 3 abnormal looking lymph nodes, then that patient should probably have a dissection or get preoperative therapy, right? But if somebody comes in with just the one abnormal looking node with cytology, I think you can ask yourself retrospectively, just like they did in the Memorial data set, I think you can ask yourself, would I feel comfortable applying Z11 to this patient?
Okay, I think we have to finish.
It's a pleasure to have you.
Thank you again very much to be here in Brazil again. It's a pleasure.
And I hope to come back in other times, okay, for
Thank
more
you.
and more times.
Thank you.
Thank you.
My pleasure.
Thank you.